In the last lecture, we talked about matching, which was a way to sort of get people who are exposed to an intervention and people who weren't exposed to the intervention to look the same. We kind of stuck them together. But we talked about a lot of the problems when you actually try to match people. It's just really hard to do. So enter propensity scoring, which is a specialized statistical method to match people together in an observational data set. So let's walk through our goals. I'm going to introduce the concept of propensity scoring, which is a way to deal primarily with confounding by indication. We'll discuss the differences between being the sort of person who does a thing and actually doing the thing, show how propensity scores improve upon matching strategies, and give some hints about interpreting them. So to get started, we went out and tried to figure out what type of person people we met actually were. So we're out here to talk about propensity scores, which is when you use a set of characteristics to predict a certain exposure. Now, in medical studies, we're often predicting medication usage, but we could, in theory, use someone's characteristics to predict anything about them, which sounds a lot like stereotyping. So I'm going to go ahead and try to stereotype some of these nice Yale students and show you how it works. All right, so judging from the pink hoodie and the dark jeans, a little bit of facial hair, I'm guessing you're a computer science major, is that correct?
Yeah, that's a pretty good guess.
I'm going to assume you write Harry Potter fan fiction.
No.
Judging from the backpack, from the watch, I'm going to assume you're a big foosball player, is that correct?
No, I'm awful at foosball.
So I'm noticing that your jeans are ripped. You've got the white sneakers. So judging based on this, I'm going to assume that you are a big fan of Frozen the musical.
I am.
I'm going to assume you run a Christian Minecraft server.
Very false.
All right, so I am noticing your cow print backpack and your flannel button down. And so I'm going to guess that you are a big cricket player.
Oh no, that's not right. No.
I'm noticing that you've got your Yale garb on, so I'm going to guess you're an athlete. Is that correct?
Not a varsity athlete. A little bit of IMs, but.
So I am sort of, getting a first impression about you. I'm looking at the earrings, the whole thing, and I'm going to guess that you are really good at Smash Brothers. Is that correct?
Occasionally, yes.
I'm going to assume that you retouch old photos on Reddit.
I do not have a Reddit. No.
All right, so I'm noticing that you're wearing shorts on a brisk spring day. So I'm going to assume that you are an a cappella singer.
No.
I don't always get it right. I am noticing the Birkenstocks and your T-shirt that says "Nasty Woman." So I am going to assume that you are a big fan of the band Slayer. Is that correct?
Yes. How did you know?
That's how it works. I'm going to assume that you are a huge Battlestar Galactica fan.
No.
Now, what you just saw was us making predictions about someone's behavior based on their attributes that were observable to us. It's stereotyping, basically. And we did that to prove a point, which is that sometimes we are correct when we make inferences about someone's behavior based on the attributes that are visible to us, and sometimes we're wrong. But this is also how propensity scoring works. Propensity scores are statistical models that predict your likelihood of doing something, whether or not you actually do the thing. So for example, I am a professor at Yale, which is a very liberal-leaning Ivy League school on the East Coast of the United States. I'm 39 years old. I'm from Connecticut originally, and I'm a white guy. Okay, so those are some data points you have about me. You could build a statistical model based on a large amount of data points to suggest whether I voted Democrat or Republican in the last election. And some of these factors might might lean the model more towards the Democrat side, like the fact that I'm a Yale professor, and then some might push more to the Republican side, like the fact that I'm a white guy who tend to vote, white guys tend to vote more Republican than otherwise. It doesn't tell you what I actually did and how I actually voted, but you could have a reasonable guess. That's a propensity score regarding my voting probability. What does this have to do with medicine? Well, a major issue in observational studies is confounding by indication. So confounding by indication is a form of confounding where we recognize the fact that people who are given a drug tend to be different than people who are not given a drug. Because I'm, as a doctor, not going to give a cholesterol medication to someone who is perfectly healthy and has normal cholesterol, right? Like I'm going to give it to people who are at risk of heart attacks and who have high cholesterol, okay? So the populations are very different. How can you possibly infer if cholesterol medications are beneficial in this setting? Now, you could do a randomized trial, right? You could just give some people placebo and some people cholesterol medications, but those are incredibly expensive and hard to do. How can we do it using just the observational data of, people that happen to get cholesterol medications? Well, we can match people together using a propensity score. Remember the last lecture we talked about matching based on multiple factors like sex and height and gestational age and all that kind of stuff. Well, propensity score matching is in some ways more complicated, but in some ways simpler. We take all those factors and we put them together, but we get a single number out at the end. The single number is the probability of getting a cholesterol medication. So it's a four-step process. First, you create a statistical model that predicts the exposure. So what factors are likely to make your doctor prescribe you a cholesterol medication? We apply that model to your population. So we identify people that are highly likely to receive a cholesterol medication based on their baseline factors and people who aren't that likely based on their baseline factors. We then match people who have similar propensity scores, but one of whom actually got the drug and one of whom didn't. So we're going to find some people with a low probability of getting a statin. Nevertheless, someone got it for whatever reason, and we match them together with someone who didn't get it. Similarly, we find among the people who are really likely to get its cholesterol medication, we find someone who got it and someone who for some reason didn't get it, and we stick them together. So we're matching on a single factor propensity score, but that propensity score is actually made up of multiple factors. And then we just follow those matched pairs all the way until there's some outcome of interest like heart attack. So this sounds a lot like matching, so let's talk for a minute about the difference between propensity scores and matching. So propensity scores combine many variables into a single number, ranging generally from 0 to 1 conventionally. So you take all those factors and you come up with a probability that this person is going to get a cholesterol medication, 40% or 0.4, okay? Whereas matching tries to kind of perfectly match people on multiple factors, and as we talked about, the more factors you add, the harder and harder it is to find a match. When you're matching with propensity scores, you have to define an acceptable window, right? Someone with a propensity score of 12% to get a statin, am I going to allow them to be matched to someone who has a score of 10% or 14% or 5%, right? What is my acceptable window? And there's some conventional statistics around what an acceptable window could be that's beyond the scope of this course, but you do have to think about it a little bit. It's very hard to set acceptable windows when you're trying to match on individual factors, right? Because you have to do a window for each factor, right? Like age within 10 years, height within 4 inches, cholesterol level within 30 points. You're deciding on all of these types of things. In general, propensity scores are a little bit easier to work with, and here's a secret. You actually don't even necessarily need to match people. You can just use the propensity score in an adjustment equation. So you adjust for the propensity score as opposed to matching. So a little tricky here, and a lot of good studies that use propensity scores will do multiple versions of this. So they'll do an analysis where they match people 1-to-1 based on propensity score, and then they'll do an analysis where they simply adjust for the propensity score. And hopefully the results are pretty similar and they can stand up to close scrutiny. So let me give you a real example, again talking about statins. These are cholesterol medications, and the question is, do statins prevent myocardial infarction, heart attack? So this was a large observational study of about 4,000 people who used statins and 4,000 people who didn't use statins. And if you look at this survival curve here, you can see that the people who used statins had a twofold higher risk of heart attack. So is that it? Do we just write off statins? Cholesterol medication's no good. It doubles your risk of heart attack? Well, no, right? Confounding by indication. The people who got the statins were higher risk to begin with. So they did a propensity score analysis. They did exactly what we're talking about. They built a model that predicted the receipt of a statin based on various factors like your age and your cardiac history and your cholesterol level. And then they matched people together based on having a similar propensity to receive statins, although one got it and one didn't. And they found this, just the opposite effect. So in this case, they saw a 30% risk reduction from statins. So by accounting for all that confounding by indication, by matching people together, they found that the taking of the cholesterol medication actually reduces the risk of heart attack by about 30%. Now, if you look at the numbers down here at the bottom, you see that we went from 4,000 users and non-users to 2,900 users and non-users. What happened there? Well, there were some people that couldn't be matched. Even with propensity scores, you can't always match. There are some people that's probability of getting a statin is so high that you cannot find someone with that high a probability that doesn't get a statin, right? Imagine the guy who's had 4 heart attacks and has a cholesterol of 500, and it's like their probability of getting a statin is 99.99999%. There's no one with a similar probability out there that doesn't get a statin. It's just inconceivable. So the interpretation of this is a little tricky. These propensity scores tend to highlight the effect of a drug on sort of the middle ground people, the people who are of moderate probability to need the drug. It's very difficult to assess the efficacy of a drug in a population of people who desperately need it, or in a population of people in whom it doesn't matter at all. Okay? All right. So how do we interpret these types of results? Well, there's a couple of things you need to be aware of. One, there will be an overall effect, a propensity adjusted or a propensity matched effect estimate, like that 30% reduction of heart attacks from statin use. That's good. But you always want the authors to tell you how that effect varied across the propensity score. A lot of times, people who are very likely to receive a statin, right, the high-risk group, might do better with the cholesterol medication than the very low-risk group. So that 30% reduction is overall. You'll often want the authors to stratify their results by ranges of propensity score, in which case they can tell you, you know what, it looks like the cholesterol medication is particularly good for this type of person who seems to really need it. They have high cholesterol, they've had a prior heart attack, and maybe it doesn't matter as much for these relatively healthy people. In other words, it's likely that statins reduce the risk of heart attack among people very likely to be prescribed statins. So that's okay. I mean, that's a true conclusion. And you can say, well, that doesn't, that's fine. But there are people that are very likely to be prescribed statins that nevertheless don't get a statin. And that's an interesting group that, like, maybe that's a group we need to target and say, okay, their doctors should be a little more aggressive about putting them on cholesterol medication. But it's not necessarily true that statins help people who are at very low risk of being prescribed statins. This type of patient wasn't necessarily in the study, but imagine we had 10-year-olds in the study, right? And it's incredibly unlikely that a 10-year-old is going to be prescribed a statin. It's also really unlikely that there's any benefit of statins in the 10-year-old age group, right? Because they're just too healthy, hopefully. All right. What are the limitations of propensity scores? They are not magical. The study ends up looking like a randomized trial because if you look at Table 1 in a propensity matched study, all the things that go into the propensity score tend to be really well balanced between the groups. And you might look at it and be like, oh, it looks like a randomized trial where the ages are similar between the exposed and the unexposed and the heights and the weights and the cholesterols and everything looks the same. It is not a randomized trial because you can't create a propensity score that accounts for unmeasured confounders, right? So randomization balances unmeasured confounders, like Mojo, because that's what randomization does. If you can't put Mojo in your propensity score model, it's not going to be balanced. It does not balance for unmeasured confounders. The other thing to know is that multivariable adjustment often works just as well as propensity score matching. So I've said this a number of times. Most of the statistical simulations suggest that you're going to do just fine with multivariable adjustment. You don't often need to go down these more complex routes. So the take-home point, propensity scoring is used when an exposure is given to a very specific type of person, and you want to compare it to similar types of people who didn't get the exposure. It's a method to account for confounding, like many of the others we've discussed, but it's not the only one, and it might not even be the best one. Please ignore authors who do a propensity match study and then say that their study can be interpreted like a randomized trial. Propensity scores do not account for unmeasured confounders. I'm just going to say it again. Propensity scores do not account for unmeasured confounders. Only randomization balances unmeasured confounders between the unexposed and exposed groups. There's nothing quite like it. I'll see you next time.